Thank you very much. Thank you to Mindray and Dr. New for organizing this symposium. I'm going to take a little different view of data in the ICU. So not concentrating on the individual patient and how we predict events in the individual patient, rather how we prevent adverse events in our ICU in general. So preventable harm is a serious issue. In the United States, 400,000 people a year will die from preventable harm. A large number of those will be in the ICU. So harm is a major issue. And I'm not talking about deterioration of sepsis. I'm talking about adverse events leading to patient death. The impact is estimated to be $20 billion. Now, U.S. healthcare is extremely expensive, but $20 billion goes a very long way in hiring salaries of nurses, financing Medicare, Medicaid, covering the cost of other treatments. So preventing harm not only has a human benefit, it has an economic benefit and knock-on effects. Now, a common approach in the ICU to preventing harm is this. We have a checklist. So I'm sure pretty much every ICU here has a checklist for the prevention of catheter-related bloodstream infections, ventilator-associated events, delirium, thromboembolism, loss of physical function. There's a checklist. We check everything off every day. We possibly do prevent a lot of these actions, and we've seen it in our hospital. So we track preventable harm in the ICU pretty closely. This is the total numbers of preventable harms over time, and you can see that it's gone down. But what hasn't gone down is the bottom part of the bar, that dark blue one. Those are others. So how do you prevent others? We know how to prevent a catheter-related bloodstream infection. We know how to prevent a ventilator-associated pneumonia. How do we solve the other problem? Now, you can't have a checklist for everything. And the others are an increasing portion of the harms in our ICU, or at least our ICU. So 60 to 70% of harms in our ICU are a grab bag category of many different things that can happen to you. So if preventing these with a checklist won't work, how do we do it? And I'm going to give you a case. I didn't put it on a slide because it's so bad. I would be embarrassed to put it on a slide. But we had a patient several years ago in our ICU. The patient had a PICO monitor. And at the end of a shift, the nurses were handing off, and the nurse was explaining to the other nurse how you measure cardiac output with the PICO monitor, and you take the cold saline and you inject it into the patient. And she showed her the saline, and it was actually tap water that had ice from the ice machine in it, and they were injecting that into the patient. So that's a harm that no checklist is going to help. But when you look at it, what was the issue? The nurse was probably an idiot, but that's one issue. You can't really solve that. It was a patient boarding in another ICU. So this was an oncology patient in a cardiac surgical ICU. It was a VIP, which is always a bad sign. The unit had very high acuity. So the nurse at the time had another patient who was very sick, and the entire unit was extremely sick. This was a float RN. She usually worked in another ICU and was floated to that unit. And she was dealing with a monitor she'd never seen before. So if you add all this up, in fact, that harm was entirely predictable. We had put this ICU patient in a risky state. The entire ICU was in a risky state. But if we can predict that, can we avoid it? And, we take harm at our hospital pretty seriously. This is a cause map. This is for a trivial harm, a lost specimen. But we do it for every harm. We go back and we try to recreate the steps that led to that harm. But what if we can prevent the state that led to the harm in advance? What if we can decrease the risk state in our ICU? So we launched upon this project. This was, I have to say, a work in progress prior to COVID. It was up and running. Then during COVID, when our ICUs expanded, it sort of fell by the wayside, and it's something we're now trying to reinvigorate. But as I'll show you, there are lots of pieces of evidence that support this approach. So you can't have a checklist for every harm. Many of the other harms, however, have common roots. So staff inexperience, overload of patients in the ICU, high acuity, multiple procedures going on. And if we identify all of these common roots, we can identify a risk state in the ICU, and we can perhaps reduce that risk state. Now, nurses do this intuitively. So this is a bed meeting in our hospital. The nurses do this twice a day. They add up the number of patients in each ICU. They say how many of them are high acuity. They distribute the nurses appropriately. In fact, there's a law now in Massachusetts that you have to have a method for setting nurse staffing. You can't just say it's 1-to-1 or 1-to-2 or 1-to-3. There has to be an algorithm behind it. So nurses assess the risk state all the time, but they don't do it scientifically, and they don't necessarily do it in an ongoing manner, and they don't do it in a way that involves all of the members of the ICU. So our hypothesis is that in the ICU we can be the boiling frog, and that the risk state in the ICU can continue to rise without any of us paying attention, and that rise in risk state can cause harm. So we launched on this project, and I have to thank the Gordon and Betty Moore Foundation that funded a lot of this work. We identified the burden of preventable harm. We identified the risk states that may lead to that harm, and then we did a CART analysis to find the relationship between the risk state and the harm. So the risk state was multiple processes that go on in the ICU, and the burden of preventable harm was a list that we came up with based on various sources. And then if you know the risk state, you know the burden of harm, you can come up with strategies to improve that risk state. Now, we collect a ton of data in our ICUs. All of these machines are integrated. They're integrated not only with the machines themselves in the ICU, but they're integrated with other hospital systems. So our EMR, our prescriber order entry, our staffing software, our pharmacy software, all of that is integrated together, and all of that data can be brought together to describe what's going on in the hospital. So the methods is we took 20,000 ICU admissions, we divided them into a training and testing set. The unit of analysis, not minute-to-minute data, the unit of analysis was Q4 hours. So we assessed the risk state in the ICU every 4 hours. We identified the drivers of harm, so patient severity, that plays into it definitely. Nursing workload, boarding patients, new nurses, time of day. We identified the harms through the IHI Global Trigger Tool, publicly reportable harms, any additional harm that we thought of, and again, we developed a relationship between them. So these were the drivers of risk we tested. They had to do with the patient, so the severity of illness, the number of patients in the unit requiring mechanical ventilation, inotropes, and dialysis, demographics of the patient. Importantly, the nurse-to-patient ratio, the number of new nurses, so experience of the nurses, number of nurses from other care units, which is a common issue with us, the number of admissions during the shift, the number of discharges, because that's a lot of work for the staff, the number of times a nurse goes off the unit with a patient. So if a nurse is going off the unit for an angiography, they can be away from their other patient for an hour. That means that that patient is now assigned 1-to-3 to a different nurse. The number of procedures going on, unfamiliarity, so unidentified patients, which we get quite a few of as a trauma center, patients cared for outside of a home ICU, and the time of day. The burden of harm was these, so we collected all of these, many of them electronically, some by brute force. And you can see these are your classical harms, but also other harms like oversedation, readmission to the ICU, hypoglycemia, coagulation deficiencies, falls, medication errors, and so on and so forth. So a very large group of harms. And we were able to measure this. So we could measure the risk state of the ICU. So think of it as a gauge that goes from green to yellow to red. And this MICU, you can see, was experienced low intensity due to low throughput, good staffing, and low clinical acuity. On the other hand, if you look on this side there, our cardiovascular ICU at the same time was showing very high acuity. Now, what do you do with that information? Well, perhaps you don't admit patients to the cardiovascular ICU, you admit them somewhere else. Perhaps you stop a transfer of a patient to the cardiac ICU. Perhaps you increase the staffing ratio in that cardiac ICU. So there are interventions you can make to reduce the risk state of a given ICU. Now, is there data to support this? So there are several papers out there that support pieces of this, and I'll just go through a few of them. So this paper from Critical Care Medicine showed that mortality is associated with staff resources at a given time. So they divided the risk to staffing, workload, and patients. They found that an increased nurse-to-patient ratio led to additional harms. They saw that increased number of patients per doctor led to increased mortality, that patient turnover in the unit, so admissions and discharges, led to increased mortality. The number of life-sustaining procedures, so CRRT, mechanical ventilation, inotropes, that led to increased mortality. And also individual patient acuity. So I'm not saying that's not important, but that's important as an interaction with the environment. So all of these are things that are measurable, and with the big data we have out there, we're able to measure them and perhaps influence them. This paper came out last week. It shows the association between nurse co-patient illness and mortality in the ICU. So they took patients covered either 1 to 2 or 1 to 3 by nurses, and they found that if the nurse's other patient had high acuity based on mechanical ventilation and inotropic therapy, the mortality increased for the first patient. So if a nurse has 2 complex patients, it increases the mortality for a given patient. So again, speaking to the importance of nurse ratio and nurse assignments. Now, the entire hospital can be at a risk state. This is a paper from COVID showing, as you can predict, that the overall hospital stress increased with the number of admissions for COVID during the various waves of the pandemic. And we can measure this not only at a unit level, but at a hospital level, which is important information since many of us are in hospitals that belong to a network. And finally, this is an interesting paper from France showing that risk in one area of the hospital can lead to increased mortality in another area of the hospital. So this showed that when the stress in the ICU went up in France, there was an increased surgical mortality, okay? Because the stress, I hypothesize, the stress level in the hospital increased overall, and that affected various aspects of staffing and care in areas that were unrelated to the stress. So what are the potential interventions? You can redistribute admissions based on the stress level of an ICU. You can avoid boarding. So we commonly board patients, but maybe that's a bad idea. Distribute nurse experience, match RN staffing to the acuity, pay attention to team building. Teams in the ICU do better than people who are randomly assigned to an ICU. Postpone or cancel off-unit imaging or procedures. So become scientific about how we reduce the stress in the ICU. So this is really a paradigm shift in hospital safety. In the current state, we measure acuity based on individual patients. The risk of harm is based on the patient's clinical characteristics, and specific types of patient harms are measured individually. so CLABSI, VAE, and so on. In the future, acuity is going to be calculated at the ICU level. So how stressed out is the entire ICU and not the individual patient? The risk of harm is going to integrate the interaction between the individual patient risk and the environment, and that harms are going to be aggregated and reduced as a whole, not one by one through the checklist. Now, we did this before COVID, and I have to admit it was brute force. We had to integrate all the hospital systems manually. The computing power didn't really exist. But while ChatGPT has sort of become a meme, this is really, really a frontier that artificial intelligence can add. So artificial intelligence will be able to scan all of the hospital records at a given time, integrate all the data, and tell us where the hospital is at risk. Today, it's nurses with clipboards walking around. In the future, we're going to have a dashboard of our hospital's risks. It will improve situational awareness, so you'll walk into a unit and you'll know exactly what's going on there. It can be used in any hospital unit, so we started in the ICU, but the emergency room is a classic for this. The operating room is a classic for this, and in fact, one of the highest risk areas in our hospital is the regular patient floor, where there's very low nurse staffing ratios. Patients who are very sick get transferred there, and the monitoring is suboptimal. Can be used also at the hospital and the healthcare system level. So I'm really optimistic about the future of data in the ICU. I think it's going to help at the individual patient level, but it's going to help us understand our environment better and be able to prevent harms through improving the entire environment and not just the individual patient. Thank you very much.
Thank you very much, Danny. A very thoughtful experience. You are optimistic. I'm still concerned about how much these requirements will become compulsory and where we will have to report to regulation authorities about that. So tomorrow is another tomorrow. We have time for one question, one comment, one shared experience. Yes, please, Paolo.
Thanks, Daniel. Very, very interesting. And I share most of your opinion, also the optimistic. But here we have a problem with the privacy issue. So using this data without a formal authorization by each patient for that specific problem is presently a big, big issue. Do you face the same type of problem or not really?
No, I have to say, so when patients are admitted to our hospital, they give consent for the use of their data for hospital purposes. So none of this goes outside of the hospital. It all stays within our internal systems. Now, there are issues. Ellie mentioned regulations. So in Massachusetts, as I said, there's a law that nurse staffing can't be fixed ratios. It has to be based on acuity. So clearly something like this helps support changing nurse ratios, which administration doesn't necessarily want because they don't want to add more nurses. Also, there is a problem, by publicly displaying this data, which is the only way it can help. Does a patient say, oh, what's going on here? This ICU is red. Why am I here? Am I at increased risk? So there are a lot of regulatory and privacy issues to be worked out. But I don't think we can avoid looking at our hospitals and our units in this way.